All right. Sorry for the delay, everybody, and it's good to be with you on this Sunday, March 20th. Hope the first day of spring is a start of something really good for you this season, and appreciate you allowing me to join you today. I want to always thank our sponsors, especially Terry and the group at the Lupus Foundation of America, Georgia chapter, along with those at Emory and the Goal Research Group. And as always, just be reminded of the disclaimer that you can take a look at later. So this is where we were last month when we met in terms of the hotspots throughout the world, and just get a sense of the different colors there, obviously the US and North America, but also just Europe and Asia and Russia and South America as well. And then this is where we are as of last week or two. And obviously things have cooled off quite a bit here in the US, and it mirrors some parts of the country, but not, I mean the world, but not all. You certainly see areas of South America still being pretty active, but what really stands out is the persistence, or what happens just to be another surge, if you will, of what's going on up in Europe, which we'll touch on a bit, as well as continued activity in Asia and the Pacific Rim, going down to Australia. So this is the cases in terms of throughout the pandemic, and we are just coming off the highly infectious Omicron surge that happened throughout the world and in the US. And you're getting a sense of this increased activity that I kind of alluded to a second ago, which is this kind of slight bump here, and we'll touch upon that in a minute. So the cases are going up on a worldwide basis, although the deaths are continuing to go down as a reflection of the recent decrease, significant decrease in cases overall. You may have heard that there is a surge in China, or some outbreaks, and they have a zero COVID policy, so they clamp down very significantly. So relative to the rest of the world, the total numbers are not great, but the effects are significant in that they shut down entire cities very quickly, and that's already led to stress on all what is already a frayed global supply chain, as we all know. Europe is pretty much heading into a second Omicron wave, and we'll talk a little bit more about that. Although we don't know it to the extent to which it will, how high it'll go, but this comes weeks after the country's race to lift restrictions and further relax antivirus measures, as we are doing in this country, and there may be things to learn from that. And what's not too much in the news is that African countries are continuing to employ vaccines and dosing schedules that really offer lower levels of protection, which, on one hand, if they have relatively limited resources and certain access, then that's better than nothing, but it does cloud the prospect of stopping potential variants, because it allows a lot of low-grade smoldering activity going on. And that's what we want to prevent, actually, is another variant that will withstand a lot of the things that we're trying to implement in terms of reducing those cases. So here, it talks about an article about the surge in Western Europe, and how this is sort of a canary in the coal mine for us in the US, as it has been in all the previous surges. The question is whether this uptick in what is the BA.2 variant of the Omicron, there's two subvariants of the Omicron. What continues to be the significant variant in the US, BA.1, is what the world is recovering from and the US is recovering from. But as many of you may have heard or read about, is this kind of a subvariant of the Omicron virus, the BA.2, that appears to be much more transmissible than even the highly transmissible original strain. And it really is fueling the outbreak across Europe and is growing in dominance across the US. And it's picking up steam, especially in the Nordic countries, all the way down to South Europe. And the past 2 years, it talks about how the widespread outbreaks in Europe have been followed by similar surges in the US. So right now, we're talking about less than a quarter of the Omicron outbreak in the US being made up of this BA.2 subvariant, but we'll just have to wait and see how much it increases here. It's not a given, and we don't know the extent to which it will continue to go up, but it is something that we have to keep an eye out for. So, I like this part of the article. It's like a weather alert. Right now, the skies are sunny and bright, literally and figuratively, and we obviously hope that they stay this way, but we could have some bad weather coming, and so that's what we just have to be prepared for. So speaking of sunny skies, this is what the US looked like a month ago, and this is where we are now. And apart from Idaho and Alaska, really, and parts of Kentucky, most of the country is doing very well, and that's reflected in these curves and numbers. The curve is continuing to go down. Everything is going down except for the number of tests, which are fine, and that's a good thing. But talking about the canary in the coal mine, and this sewer data, for those of you who don't know, it is quite interesting. It's that data from wastewater can spot a rise in infections before it shows up in a certain area. So people who are infected with the coronavirus shed viral particles in their stool, and that obviously flows into the sewer system, and that can be tested for in a variety of sewage plants. So more than a third of the CDC's wastewater sample sites across the US have been showing rising COVID-19 viral particles. And so even though as a country, it hasn't quite yet signaled in terms of positive cases, there are some signals, at least if you look at the BA.2 variant, increased percentage, and then the sewage data, and what's happening in Europe and in Asia, where they were doing quite well up until recently. We have to be on guard for that. So speaking of Georgia, this is what it was a month ago. This is what it's like now, and these are the figures, which are reflect the U.S. pretty much in terms of good trends and numbers across all the different groups. But just like the rest of the U.S., Georgia obviously has to be concerned about what's going to happen in the future. But even more specifically, Georgia has a relatively lower vaccination rate than the rest of the country, and so that's going to be potentially an issue. We know that the BA.2 subvariant is extremely similar to the original Omicron variant, which was already more contagious than the earlier strains of the virus. We know that BA.2 spreads even more easily from person to person. However, it does not appear to cause more severe disease. And what has been true throughout all of the variants and continues to be upheld in Omicron variants is that the vaccines continue to be extremely effective in protecting people from severe disease, not necessarily catching it, obviously. I mean, we had this huge uptick in positive cases, but it did not reflect in terms of the overwhelming number of cases that were brought on by a lesser surge from the Delta variant. So, thank goodness for that. And we know that the antiviral drugs that we talked about last month also appear to be effective against both Omicron variants, as long as you take it within the first several days. So the early data also just suggests that people who caught the original Omicron variant will have some degree of immunity against this subvariant, but we just have to wait and see how long that lasts and to what degree that holds. But the take-home message here really is that the rules, thankfully, are still the same for the recent variants, the two subvariants of the Omicron variant. In that, the vaccination is really the ultimate, the best way to minimize severe disease. And as the specter of another surge of cases comes to play, it's good as a country to be very well prepared, but Georgia is less well prepared as a whole in terms of the lower number of vaccinated residents. We talked about last month in terms of the new therapeutics that are available for the treatment of or the prevention of COVID-19 infection. And Terry was good enough to find a really nice side-by-side document that compares all the different treatments that are currently available. And obviously this slide is too small to read, but she did add it to the LFA Georgia chapter resources page. So please go to that, or you can go back and type in this very long link and you should be able to download it, or you can search for it online. Other things that have happened since last month: the mask mandates are ending in non-healthcare settings, even at Emory University, where I work. The university section pretty much is doing away with their mask mandates, although they remain in play for healthcare settings in certain research areas. The oral antiviral drugs that we talked about last month are becoming more available, and as a result, they are part of a national strategy that President Biden mentioned in his State of the Union speech, which allows for test to treat as a strategy, meaning at the point where you do get a positive test at a pharmacy, for example, you will get for free medications, antiviral medications, to minimize the effects of that infection, which will obviously go a long way in improving outcomes. We've heard about Moderna and Pfizer wanting another round of boosters, so the second set of boosters. On Thursday, Moderna formally requested authorization of a second booster for all adults over 18, whereas Pfizer earlier in the week requested a second booster only for people over 65. And it's really, the difference. Moderna wanted more flexibility for governments to decide which age groups would most benefit from the booster, and trying to stay like one step ahead and allowing more nimble decision making. But that's going to be on the horizon. I do know some of my colleagues at Emory and others throughout the country are suggesting or recommending another set of boosters already for immunocompromised individuals like those with lupus. So, we'll have to talk about this more in the future. And there are things that are still on the horizon. Things circle back. This Novavax vaccine, which had a lot of trouble. You might remember early in the pandemic, it used more traditional technologies, and it was another way of getting vaccines out there, but they had a problem in their Maryland plant, and it was just sort of a big mess in terms of getting it out. And it was bypassed by Moderna and Pfizer and J&J at the time, which had production well in hand and good data. And so why even bother with this? But it's interesting that it's coming into the picture again now, in that the company has resolved many of the manufacturing issues. And what's interesting about this vaccine, as I mentioned earlier, is that it uses traditional protein-based vaccine technology, which has been around for a long time, and it's been used in flu shots and hepatitis B vaccines in babies. And so it's a technology that we're all familiar with and people have potentially been exposed to for many, many years. And that may alleviate some of the concerns in some people that are against the vaccine. So it'd be interesting to see if this as an option would boost the receptiveness of vaccines as well. And I just read an article like an hour or two ago that I didn't have time to make a slide, but it's in CNN about the J&J vaccine. And J&J was available early. It didn't have to be frozen. It had special freezers, and a lot of people got that. And there was a concern about some effects from that, and so it wasn't as much in favor. But it's come back in the sense that throughout the recent Omicron variant, it's shown actually to have a much longer durability of response, greater, at least 6 months. And has done very well throughout the surges, along with the other vaccines too. So, it's funny. The more we learn about these things, it seems like we're learning even more. So stay tuned regarding additional vaccine information. So I wanted to. This is a slide that I showed last week about the effects of the virus in terms of the disability it causes, and in many people that have severe disease and some that don't have much severe disease. And it's a lesson that has been taught to society through previous pandemics. It's a lesson that we know very well as a lupus community, in that when people have an onslaught of their immune system, and it's not through an infection necessarily, but in the case of lupus, unknown causes that come together and causes immune activation, it really leads to not only the problem of the immune system itself, but the subsequent symptoms, the inability to function as well, and the disability that results from it. Along with all the implications that come with it. So there's interesting information regarding the long COVID syndrome. And here's a video from the Wall Street Journal that I want to show you. It's about 4 or 5 minutes long, but it has some good information that will allow us to hear the rest. And I'll discuss afterwards.
The only way to keep my oxygen levels even in the 80s was to remain on oxygen and in bed.
This is a patient experiencing long COVID, a term that describes a wide range of lingering symptoms that can last anywhere from 4 to 12 weeks or more. Estimates about the prevalence of long COVID range depending on the study and how they define long COVID, but one recent review found that more than half of unvaccinated COVID-19 survivors experienced long COVID. For the vaccinated population, another study found that the percentage dropped to about 19%. But as the third year of the pandemic approaches, doctors are searching for more information about what long COVID is, why it happens, and how it can be treated.
We know that SARS-CoV-2, the virus which causes COVID-19, is primarily a lung infection.
Dr. Patty Santongo and his colleagues from Penn State looked through 57 peer-reviewed papers to better understand long COVID.
But we found that every organ from the brain, through the cardiac system and the gastrointestinal system, even the skin, all these organs were affected.
A patient-led initiative showed people with long COVID display over 205 individual symptoms that affect 10 different organ systems. Research pinpointing the exact cause of long COVID is ongoing, as is the question of how different variants, like Omicron, impact one's likelihood of experiencing lingering symptoms. But scientists are exploring 3 main theories about its source. The first is that parts of the virus are still present in the body and periodically get reactivated. The second is chronic inflammation, which is caused by leftover inflammatory cells that affect the organs and cause inflammatory symptoms like stiffness and fatigue. And the third suggests long COVID is an autoimmune reaction, meaning that the immune system is in overdrive and the body is producing new harmful molecules that attack its tissues.
I think at this stage, it's important to point out that all three could be possible.
Dr. David Petrino has managed over 2,000 long COVID cases.
Many people overproduced inflammatory molecules during their acute infection, and they did so in a way that was not correlated with severity of acute infections.
In these cases, even patients with mild symptoms could experience something called a cytokine storm. Cytokines are molecules that regulate the body's inflammatory response, but overproduction of them can cause damage to surrounding cells, like nerve tissue.
Nervous systems that are associated with the autonomic nervous system, such as the vagus nerve, it's the longest nerve in the body. It has projections that touch pretty much everything in the body. And so depending on which branch of a nerve like the vagus nerve is being affected, can produce symptoms that vary from, a rash on your skin all the way through to heart palpitations or cognitive issues.
Santongo's review found approximately 1 in 3 COVID-19 survivors was diagnosed with generalized anxiety disorders, 1 in 4 with sleep disorders, 1 in 5 with depression, and 1 in 8 with post-traumatic stress disorder.
That inflammation from the cytokines can injure the brain or the neurons, and that can lead to the manifestation of neurocognitive outcome.
With the wide scope of long COVID symptoms, Dr. Santongo says treatment needs to center the patient.
So the treatment aspect to me is developing kind of like a treatment plan, kind of one-stop treatment center for COVID-19.
This is the approach at Yale Medicine's post-COVID-19 recovery program. First, patients are referred and assessed based on their needs. Then, the necessary doctors are brought in.
As much as I would love to say every patient is exactly alike, they really aren't.
Dr. Denise Lutchman Singh is a pulmonologist and is leading the program at Yale. She says variability is the one constant.
It actually is interesting because you have to kind of think of post-COVID care as a little bit more of personalized medicine, which we should have probably been doing anyway in medicine.
One scenario that complicates treatment is when patients report persistent symptoms but show normal testing. It's these patients that have led Yale to take new measures in search of answers.
We've started doing a little bit more invasive testing, something called a cardiopulmonary exercise test, putting IVs into the large blood vessels of the neck or into the arteries while the patients are exercising. Some of the findings that we've found in those patients have been similar to test results of that particular test in patients with a history of chronic fatigue syndrome.
Another finding showed that while oxygen was reaching the vital organs, once it got there, it was not used normally. This could explain why some patients feel shortness of breath.
That was one of the things that led to more questions. Well, why is this happening? Is this something related to antibodies or inflammation or nerve dysregulation? And then the other question was still, well, if this happens in one patient, is this what is happening consistently across the board for every patient?
2 recent papers bring new information on who may be more susceptible to long COVID. One of them cites the presence of autoantibodies as the most prevalent among 4 potential risk factors. Autoantibodies are usually associated with autoimmune conditions, such as lupus and rheumatoid arthritis. But Dr. Petrino remains cautious.
And we need to keep following up on these things to better understand what's happening in larger sample sizes. So, these are certainly things that should be published, and we should have them at front of mind as we move forward. But they shouldn't be definitive, and I don't think the authors intended them to be.
Researchers from both studies said their findings better inform our understanding of long COVID, with a researcher from the Cell study saying the paper's findings will likely help guide further research. Although the science of long COVID has evolved, big questions remain about its impact.
I have patients who are nurses and firefighters who were fit, who have climbed mountains and run marathons, and they are limited. And I don't think we understand in society what this is going to mean for us in a couple of years, but I think it's going to have a massive impact.
So I'm sure there are several things that connect to you from this piece and the discussion on long COVID. If you have lupus or a caregiver of somebody with lupus, we have chronic symptoms with normal tests. We have inflammatory states. We have production of autoantibodies. So I think there's way too early to answer in a definitive way, and I'm sure there's plenty of questions. But the way that I look at this is that I hope that it will open our eyes and increase our knowledge as to what's happening in lupus, because there's a lot of similarities in both, obviously. And at the end of the day, there may be some significant differences, but I think there are going to be enough similarities that as we learn more about long COVID, hopefully we'll be able to learn more about long lupus, the chronic symptoms that occur in people with lupus. Because in lupus, we know that there are triggers, one, probably multiple, and it's probably different for different people, exactly what those triggers are and in what combination. And that's one of the major challenges in lupus, is to better understand these constantly changing and different triggers for each individual. This variability that was alluded to in long COVID is multiplied exponentially in lupus. But we do know that we have a window in that in certain people, we have a pretty good idea, better than others, what triggers lupus. And one thing is, you might have heard about drug-induced lupus. It's where people develop lupus-like symptoms, autoantibodies, ANAs, a lot of the symptoms of lupus, but it's right after being exposed to a certain medication. And if you stop that medication, those things will get better. Many of the people do eventually develop lupus later on down the road, but I think that particular situation, and it doesn't happen very often, but when it does happen, we have a good idea that there's something about that medication in that particular individual at that particular time that triggered the inflammatory response, the production of autoantibodies, and so forth. Here in COVID, we know what triggers the disease. It's a virus. But just like lupus and drug-induced lupus, not everybody with COVID develops long COVID. So not everybody with these exposures in lupus develops lupus or long lupus. One of the things that you can think about is the ANA test. And we know that almost everybody with lupus has autoantibodies, especially this anti-nuclear antibody test. But we do know that it's present in about 30% or so, plus or minus, in the general population, and the vast majority of those people don't develop lupus. So what is it that takes them to the next step? So many mysteries here, and so many questions that we've been asking for a long time. It's been so difficult in lupus to really get a handle on it and move the needle and to find answers to make a difference for you all and our loved ones. But maybe it takes this horrible event of a pandemic that we can have a silver lining in that, in all the studies that are going on with unprecedented focus from all these different medical subspecialties and significant resources put behind that, we'll find out a little bit more about the impacts of autoantibodies and chronic inflammation and long-term symptoms. But it does, I can understand the questions like this that was posed last week about having lupus or an autoimmune disease, reading stories and hearing about this long COVID. What happens if you have both? If you're someone with lupus with autoantibodies, chronic symptoms, and then you get COVID, is it a double whammy? Is it going to be twice as worse and more significant in terms of these long COVID or long lupus symptoms? And I think that's number one, way too premature to ask that question in any sense. We don't have any data to show that that's a significant issue or even happens at all. We're trying to figure that out. But just because you have one, it's not as simple as adding another and doubling the effects or increasing the effects. Having COVID in somebody with lupus may not do anything at all because the immune system's already revved up. There are already antibodies. It may increase those things, or it may do something in between. And all this to say, I haven't really seen a significant change in the perception of long lupus symptoms, but in people who have developed lupus, but it hasn't been studied very well. We haven't had enough time go by, and we're very interested in it. And hopefully I'll be able to tell you some exciting news from our own goal cohort along these lines, because that's one of the major questions that we want to try to help answer in our next phase, assuming that we can get some additional funding from the CDC that we applied for. So we'll keep you abreast, but hopefully these stories will be more hopeful than scary to you all, in the sense that, again, I have not had any sense that it's a significant problem in terms of worsening symptoms for lupus. And if anything, it will shed light on what is happening in lupus, at least in part, so that we can make some advances in this field. There's so many things that are being learned. In addition to what's in the video, this is a study that has not been peer reviewed yet, but it is out in the public domain. And it's a study of 37 volunteers with self-reported long COVID symptoms of fatigue and chronic fatigue after having COVID. And they were not hospitalized. They were compared against 52 individuals that were matched based on age and sex. And they made a laboratory visit about 6 to 26 weeks after the diagnosis of COVID in that group. And the researchers ran a battery of behavioral and neurophysiologic tests to evaluate the central, peripheral, and autonomic nervous systems. And so what we have here is that this post-COVID fatigue group had increased levels of peripheral fatigue that suggest some metabolic changes in the muscle fibers that may be leading to reduced strength. There was changes in the brain in terms of intracortical facilitation is the term that they used. It's just kind of signaling of the nerves in certain parts of the brain were different. There was an increased resting heart rate in those with post-COVID fatigue. And there was some changes in the blood oxygen saturation too. So this is very early. It's not meant to be taken as gospel yet. It's a very small study, relatively speaking, and it has not been peer reviewed, but it just gives you an idea of what is being looked at, some potential clues that are starting to be seen that have still yet to be confirmed. And we'll see what happens. But, again, I think this is just going to be even more helpful for fields like lupus than anything else. I'm going to finish with a question that didn't quite fit into any category before. Someone who was diagnosed with COVID and then developed a blood clots. And are the clots a result of having lupus, and will the clots return? I can't answer on an individual basis with whether the clots will return. But I can tell you that, there are reasons in lupus for people to develop clots, and you all are aware of that as much as I am. Those with antiphospholipid antibodies, those that have a lot of protein loss, but just having lupus in and of itself somewhat increases the risk, although chances of not having a clot are much greater, but still relative to the general public, having lupus and having a variety of other things related to lupus can increase the risk of having a blood clot. Where COVID comes in with blood clot really is when the people are very, very sick and they're in that cytokine storm that was in that video, where the immune system is just heating up like it's like a core that's melting in a nuclear reactor. At that point, it's almost impossible to stop, and it's causing damage to itself and melting down. That's what's happened. That's what can happen in a very severe infectious disease like COVID, and that's what gets people into trouble. And that is a situation in COVID where you may have heard of very, very significant blood clots and huge problems as a result of that. So how they work together, lupus and COVID and blood clots, we're not really sure at this point. So that's the end of my talk this week. And just remember the resource page on the LFA website here. Thank you, Terry and the group. They have links as well to other resources, including the national website. Please continue to send questions leading up to our monthly talks that are the second Sundays, and hopefully it will stay true to form next month, which should be April 10th, and I look forward to seeing you then. And I just wanted to end by, and Terry didn't ask me to do this, by the way, but I just want to highlight the fact that the LFA walk is heading back in person in 2 locations here. You see Piedmont Park in Atlanta on April 30th, and Glen Hills High School on May 21st. And so Lord willing, I'm be able to see some of you there. It'll be outdoors, and it'll be a great time to socially distance, but at the same time be sociable and to walk and to refresh our mental status and to really remind each other that we are indeed around and we're still a community. So thank you all, and I hope you have a great week.